So based on all this, this is how we classify our patients. Okay. So we say category 1 are asymptomatic, category 2 are symptomatic but they have no pneumonias, category 3 are pneumonias but not requiring oxygen. So we could come up with some criteria there if you want if you're doing clinical trials like SpO2 less than 93% on room air and all this stuff, but patients who do not require oxygen. The category 4 is pneumonia that requires supplemental oxygen. So the Kaletra study that I showed you earlier in NEJ yesterday was done on category 4 patients, pneumonia patient requiring supplemental oxygen. So in this, we now know if you were to start Kaletra in category 4, it is not useful. And our 2 patients showed us that. We started them on category 4 Kaletra monotherapy. They continue to deteriorate while in Kaletra monotherapy. Category 5 is critical. Okay, next. Okay, the drugs that have been tried in COVID. Kaletra has been tried in the dose of 2 tablets twice a day. Chloroquine has been tried in milligram twice a day. Hydroxychloroquine has been tried dose of 200 twice a day. Interferon beta 1B has been tried in 250 micrograms every other day for 7 doses. These are drugs that we do use currently. Ribavirin, there are few doses, few different dosing regimes that have been used currently. Favipiravir is actually a Japanese drug. It is now approved. So I think probably it's the first approved drug under any FDA. China approved this drug for use for COVID-19. Probably the first approved drug in any FDA currently. Remdesivir is a drug from Gilead, which has been used for Ebola, and it seems to be the most promising drug for COVID if you can get access to it. But and we have tried. I think Malaysia won't get access to it for the time being because of various reasons. So I don't think remdesivir is now in our armamentarium currently for the foreseeable future. Favipiravir is something that we will try and acquire. We are trying to ask people to bring it in. So currently, so that might be a drug that we might get access to in the future. So currently, we'll have to play with any of the 5 drugs in different combination, ask ourselves which one works. Okay. Next slide. So I didn't put it as a, sorry, go back, right? Okay. I have not put my treatment regime as a slide because I'm just worried if I put it today, we will change it. Okay. So I'll tell you what we are currently doing here, right? Okay. Go back to the 3 seconds. Next slide. Okay. So if somebody has pneumonia and not requiring oxygen, this is where we will start our treatment. Okay. So what did I tell you before? I told you that number 1, people with comorbids and elderly do badly. Second thing I told you is if somebody has got fever, fever is one of the warning signs. Fever is a warning sign. In people who have got no comorbids or people who are young, most of these viral pneumonia patients have a very strong fever response. But in the elderly, as in any other medical conditions, or people got multiple comorbids, the fever is not very prominent. And so the fever is a good marker in some age groups, may not be a good marker in some age groups, which is nothing unusual. It happens in anything in clinical medicine. The same thing in any sepsis. Problem. Fever is not a good marker is not a reliable marker for severe sepsis. Right? And so based on the fact that the risk factors that we have, risk factors age, we use age more than 60, and we use any of the comorbid factors. If somebody has got a risk factor, these people are going to do badly. So these patients, we will give them, in stage 3, we will give them treatment. Pneumonia not requiring oxygen. So chest X-shows opacity, they don't require oxygen, we will give them antivirals. The antivirals currently that we are planning to use is Kaletra plus hydroxychloroquine. we still want to study this combination and see whether it is safe, because we want to make sure all these drugs prolong QT intervals. So we need to check whether it's safe or not. So currently, this group 3, we will start them on Caletra or hydroxychloroquine. If somebody as young, no comorbids, we would want to look for fever. If they have fever and stage 3, we will on treatment. If they don't have fever, we may not start them on electron chloroquine. And so what we do is we divide stage 3 and stage 4 into 2 categories: 3A, 3B. 3A means afebrile, 3B means febrile. So if it's 3B, we will give them on treatment if they have no risk factors. If there are risk factors, we will treat them at 3A itself. Okay? So 3A, 3B. 3A means afebrile, 3B means febrile. So if you have no risk factors, we will wait for 3B before we treat. If they have risk factors, we'll start them at 3A. The drug that we use is Caletra and hydroxychloroquine. While on this treatment, if they continue to get ill, we will add a third antiviral, which can be interferon, as whatever, depending on the supply. In Sungai Blue, we tend to use interferon, but in where it's not available, people use ribavirin. So 3 antivirals for when they get ill. That's a treatment regime now. Once we have bit more understanding of how these drugs are available, we will soon release a consensus document after discussing with all ID physicians in the country and other relevant people. So this is what we do currently as treatment. That's it. I think that's all. Thanks.
Okay. Yeah, thank you very much. I think we have now about half an hour has gone. So we would open for discussion, and the paper that Suresh has referred to, we eventually have the learning point, past and references, and we will come up with a tutor which is the same name, updates COVID. So we have in tutor shared to all the public. We say these are the local experience. So we open for question and also sharing from all the other sites out there. And we identify who to talk first, right?
Yeah.
Maybe you can talk. The combination, maybe my question is, do you have dengue? In Thailand, they have of COVID with dengue, and you know dengue is endemic. So have you any concern?
We have seen patients, Singapore also shown, as reported it, we have patients who have dengue serology positive, but later turn out to have COVID-19. So is it dengue or is it COVID? We don't know yet. And so it could very well be just COVID, and the serology is turning positive. Shalini is a question.
Shalini. You can type your question. Is that okay?
Okay, me retype.
You read out the question.
No question.
So we
Yes.
when you can hear.
Okay, there are actually 2 questions in the chat box. One is actually asking, do we know the duration of treatment?
Do you know the duration of treatment?
So it's less than 14 days. Traditionally, it's about 10 to 14 days, but not more than 14 days.
One case 2 had hemolysis.
No hemolysis. We never, no drop in hemoglobin.
What was the specificity for RT-PCR being used?
Obviously, it very much depends on how you swab. second question is, what is the gold standard? Because our gold standard is still RT-PCR. And I presume the labs went through a big learning curve to do RT-PCR. Initially, all the RT-PCRs were verified by IMR. And once they are confident, only then they were allowed to do it. So the answer to your question, that's the gold standard. We don't have anything else to use. The more important question is, can RT-PCR be negative and then the guy can still have COVID? Yes. We had one patient who's only now recovering from a bad COVID-19. We took 6 days to diagnose him because the first swab was negative, second swab was negative, but by now we are able to recognize a clinical picture that looks like COVID. White cell count low, lymph node dropping, the white chest x-rays are multifocal peripheral opacities. So based on that, we didn't believe the swab was negative. So third one, we sent a sputum. And so when he got a sputum, the sputum was positive. So the lesson for us is, by the second week of disease, if somebody can produce sputum is superior to swabs. Okay, the first week of disease, maybe the swabs are better. By second week of disease, somebody's got a pneumonia, somebody can produce a sputum, you don't need to send a swab. A sputum is superior test.
Next question, the medicine needed for renal adjustment or liver adjustments?
Caletra and interferon doesn't need. Both the drugs that we need, they need. Yeah.
Summary for QE, prolonged QT for antivirals, any other cardiac complications encountered so far?
No. That's the biggest one. The QT is one that's worried about because COVID-19 is known to cause myocarditis. And it is now happening in the sick patients are usually already elderly and comorbids. So prolonged QT is going to be a big problem for us, right? And other than that, we didn't see. It's all hearsay. The patients who died all had bradycardia. And so we need to go through this part of the heart and the COVID-19. Is it because of the drugs, or is it because of the myocarditis itself? And so in the days to come, we are going to monitor very closely the QT interval. So we've got a mission to keep on doing the strict QT intervals. Other than that, we're not seeing anything else. POI definition, I'm not sure. We should ask public health. I think there will be a decisions to increase the number of countries there, but I can't understand how they can increase the countries. It's the whole world. And so it is, anybody comes back from any part of the world, or any part of Asia, now we have to think of COVID. So eventually the POI definition becomes irrelevant. It becomes just a clinical criteria. There is no EPID criteria in POI. Possibly a reinfection, I don't believe it, because I think it's intermittent shedding or the way we take the swab. I can take a swab. We just used to joke with our doctors, please take a swab in a way that the swab becomes negative. Because you can take a lousy swab, the swab can be negative, and then 1 week later you can take a proper swab, and the proper swab can become positive. And so I've not heard of anybody becoming sick with reinfection, but we hear about patients getting, after swab negative, they become swab positive. But I think it is intermittent shedding or the first swabs. We are all our discharged patients. We are bringing them back for day 7 and day 14, and we are swabbing them just for the first few patients to see whether there is really reinfection. Singapore said they also not seeing. How often do we do? We are slowly decreasing the number of monitoring of OPS. Serology we don't do, right? Serology we don't do. And I can tell you, because of talking about serology now, I can tell you that the RT-PCRs, the rapid test kits that are available out in the market, our current opinion is they're all useless tests, shouldn't be used. We shouldn't use those kits for routine diagnostic purposes. And so serology we don't use for use in our diagnosis of COVID-19 currently, right? The PCRs we do at weekly intervals or at every 72 hours or at 1 week intervals. And once they become negative, we repeat after 24 hours. So once they come into a hospital, we might do it anywhere from 72 hours to every 72 hours to every weekly. And once they've improved and one test negative, we repeat one more 24 hours later. 24 hours results negative, they can go home. Two results 24 hours apart, negative, can go home. Does recovery confer immunity? I don't have the answer to that yet. We have not had yeah, that's something that I have to ask Dr. Go, whether she will be interested in convincing the TCM arm of NIH to do a study with a Chinese drug that has already been used.
Yes. So there's a group of doctors and we have pharmacists who are trained in TCM. They're exploring it. If you do it in clinical trial manner, takes some time with the protocol. So there may be some case study intervention. If anyone interested, contact me and we can link up a group. But Swaranjaya CRC team will be looking to that.
Hey Joyce, you should be looking for neurological presentation. I have not looked at it closely. I'm looking only at as respiratory. I have not heard of neurology presentation so far, but there might be something in fine print that if the patient is, should we stop? Most international guidelines are saying not to stop. In our clinical, we are planning to collect some data to look at this too. How many patients on AC inhibitors currently, and how the current guidelines say don't stop AC inhibitors, they're already on it. Any role for steroids, ARDS, methylpred, yeah, we don't know the answer to it. So I think there is a small group of patients who will benefit from not high dose steroids, steroids, some benefit of steroids because there is some patients who are cytokine release syndrome, CRS. The trick is to decide who it is. So we are still learning and we are planning to do some studies to look at who needs steroids. That's a question. That's a clinical question that we need to answer. So if a patient is asymptomatic, day 1 to 7 of illness, how frequent do you monitor LDH, CRP? So if asymptomatic, we will still do at least full blood count. We will do the full blood count at least daily or every other day. But chest X-rays we do only when necessary. The full blood count we might do more often. The CRPs also we don't do that often. Any evidence of high dose? Yeah, we have not tried it. We have not tried it because those are where this I showed you earlier. The first case, despite what we gave, he got better by himself. We know that Calatrava never works. We know he got better with interferon so fast. So we should be very careful when we use these therapy on conditions where self-limiting in a mild disease. So if you are giving somebody a treatment in a mild disease patient, it has to be in a trial setting. Otherwise, you are treating somebody who is going to get better anyway. So that's why we are avoiding giving drugs in mild disease without, if you are not in a clinical trial setting. Age is reported. We have age for all these patients. Many of these patients are the current cohort, the latest cohort that we have from the Tabligh group are older, and that's the reason why we have AG, right? Not age. Okay, brilliant. AG, gastroenteritis. There is some patients have diarrhea, but once we start them on Calatrava, everybody has diarrhea, then it becomes very tricky for us, right? Tricky for us to do. And so a lot of patients have diarrhea, it's probably because of Calatrava. Yes, that's what we want to do. At stage 1 or 2, I think with help from, with lots and lots of help from NIH, we will probably embark on a study to look at starting patients on stage 1 and 2 to prevent deterioration, which has to be in a study setting. Without a study setting, if you do, we will never know whether it works or not. Encephalopathic or reduced Jesus, would this be a complication? We have not seen anybody with, we intubate them very early. We intubate these patients very early because we don't want crash intubation. And because we don't want to go in very often into the room to sort these things out. First few days we sedate them and sometimes even paralyze them, right? And so we may not pick up encephalopathy or reduced GCS in these patients if they had one, because the lung takes over and we treat the lung. So we don't know the answer to this, right? How to approach, there's no history of contact, should we screen what level of PPT use, right? Okay. I mean, slowly you're moving away from COVID-19, right? But I agree. We want hereafter to have a pneumonia cubicle. I think Dr. Mahiran has come up with the guidelines yesterday. Dr. Mahiran has come up with the guideline yesterday. So what we want to put a universal treatment, PPE for all pneumonia patients. Okay, all pneumonia patients admitted, we should have a basic PPE. The basic PPE is surgical mask, gown, and eye cover. Okay, that's what we should do for all pneumonia patients, right? And then there was some difference of opinion. Some of us might start sending COVID-19 for all admitted pneumonia patients for the time being to see whether there's COVID-19. Some said they will send only for those, they will send COVID-19 tests routinely for people who got pneumonia and the pneumonia looks viral. How do you know pneumonia looks viral? The white cell count is normal, CRP is not high, or lymphocyte count is low. So any of this as it looks viral, then we'll send for COVID-19. But we should start sending COVID-19 tests in patients who do not have PUI definition. We have to start sending more. Positive dengue serology. I also read false positive. Right? Yes.
We still have another 5 minutes. 40
okay,
minutes.
fine. Okay. Okay. The question of dengue, yeah? Right? I think in COVID-19, the platelet count never goes down that low. It doesn't go down that low. It's 150, 180, and all that. So if somebody's got a double-digit platelet count, and I would think of it rather than COVID, number one. And number two, respiratory symptoms are not very common in dengue, right? It's like COVID, number two. And then number three, I will look out for hemoconcentration. Anyway, in febrile phase in dengue, you're not supposed to give much fluids. So I don't think fluid is a big issue to differentiate COVID and dengue. I think clinically you can manage to differentiate them. We don't know, but the guys that we saw, a lot of miraculously very fast, but I presume they will have some exertional dyspnea. Any benefit of starting beta interferon early? We don't know the answer to it. It's an expensive drug. I don't think they're widely available. So whenever we choose a drug, we have to ask ourselves, is it available in huge quantities? Otherwise, then it's not worth starting. I don't think any of us are planning to use beta interferon early. Okay, we are planning to study hydroxychloroquine. We are planning to study other drugs, but we are not planning to study beta interferon early. Yep. We are looking at it. We are looking at H score. We are looking at all those things to see which is the best marker. So currently, that's our question that we are pursuing now. We want to pick up which patients have cytokine storm, and so which patients require steroids. This is one that we're looking at it very hard currently, right? As we get more information, we will bring it up here. Somebody's asking me regarding first episode of, I have not seen one, something like that. I've not seen one. Okay. Others can read this, isn't it?
Can.
So I don't have to repeat the questions, right?
But someone shared experience there.
Right, correct. I have not seen it.
They had fatigue and treated with steroids,
correct.
And they seem to respond.
I have not seen that. What are the alarm signs to consider intubation COVID-19? Not really alarm signs. I mean, we go for hypoxia. Once they're on face mask, we'll already refer NS and get them. The deterioration can be very sudden, and so we tend to have a short threshold to intubate because we don't want crash intubation. We want to intubate in a planned manner, and so we tend to intubate earlier than necessary because we just don't want to intubate. What would you advise for pneumonia patients in outpatient clinic now? They only have what do you advise if we see pneumonia patient outpatient clinic now? They only have a full blood count. Yeah, I mean, full blood count will try to differentiate for you whether it's viral or bacterial. If it's viral, then normal white cell count and low lymphocyte count. So you need to have a decision to make, right? One decision will be is maybe this patient could have COVID. It very much depends on how much COVID you have seen in your neighborhood, and you can always refer them for COVID testing. The other option is to follow what UK NHS does. If anybody has got a mild URTI, they ask to go home and isolate themselves. And if they fall sick, if they feel sick, they come back. We give them a way to. So you could give them, you could treat them accordingly, but in the back of the mind, if it's nagging, that could be COVID, they go for testing, or you could give them, isolate themselves and give them a health alert card. Health alert card and HAT, health assessment tool, that is available in the guidelines. Health alert card and health assessment tool. So when you give that, so we want them to come in. If they resolve by themselves, it's okay. They've isolated themselves, so great. They won't spread the disease. You're okay. If they have to turn ill, they come into the hospital. But if they're in hospital, we will. So in a hospital, hospitalized pneumonia patients, we want to test. Outpatient pneumonia patients need to go by ear and decide whether we can send them for isolation, self-isolation themselves, right? White cell count is normal or low in addition to lymphopenia, because if the white cell count is high, 25,000 in a sepsis patient also there might be lymphopenia. Remember, the lymphopenia and low white cell count is a useful marker in early COVID infections. If somebody is in ICU for a long time, they can have high white cell counts. That's not very useful. So whenever we talk about full blood count to diagnose COVID, we're talking about it early, the first week of illness. Later in the disease, you can have high white cell counts. I'm regarding H2 scores. I'm asking you to hang on first. Don't give steroids. We need to know more before we use H2 scores to decide on giving steroids in COVID-19. So don't use H2 score to treat as yet. Basari cases turn out to be positive in COVID-19 to manage all cases. Yes, that's what I'm saying. The word. That's what I'm telling earlier. So all pneumonia patients in the hospitals, you have to have basic PPE. What is basic PPE? So WHO says surgical mask, eye cover, gown and a glove is enough. That's what WHO says. UK NHS says the same thing. Surgical mask, eye cover, gown and a glove. That's all you need to manage COVID-19. Our setting, what we do is we do have use N95 mask when we go to the room, positive patient, and so we shouldn't extend it to all pneumonia patients. Then risk stratification is not so great. So when I mean full PP, I'm talking about surgical mask, eye cover, gown, and a glove. I think all pneumonia should be managed that way currently. Okay. What kind of gown? Good question. So we have. So let's look at gowns that we have. We have a apron that just doesn't sleeveless, right? That is sleeveless. Then we have a apron, a water-resistant apron that has got a cuff, a white color cuff. And third one, we have again another plastic apron. This plastic apron, which has got a ring enough to go around your thumb. These are three gowns we have, right? And so the plastic apron is not useful. The white apron is not useful. It is either the one with cuff or the one with blue gown. So in Sungai Buloh, we are getting short of gowns, and so we are currently going towards the blue gown. The blue gown, which has got a ring around your thumb. It is plastic. It is water resistant, and so we are using that. We are using that as our gown. How long do you want this patient in the hospital? Once they are better. So we do currently we are using viral loads, isn't it? We are using viral loads. If the patients are quickly better, 2 consecutive viral loads are done. We do change. We do send them home now. any scoring, that's a scoring that we use, 1, 2, 3, 4, 5. That's a scoring that we use currently, right? That's how we used to monitor our patients. So every day you go to awards now, against every patient there'll be a score. And every time our doctors know how to score these patients. These are the scores: 1, 2, 3, 4, 5. And for 3 and 4, we have 3A, 3B, 4A, 4B, right? 3BD, I think, yeah, we're not sure whether it makes a difference. I personally think if you're using Caletra in a Ryle's tube patient, you should use syrup. Don't. Okay, if syrup is not available, then you have to do all sorts of things that there's got no evidence. The manufacturer of Caletra says don't crush Caletra. If you crush Caletra, it doesn't work. Okay, so if you're using Caletra 3BD, then know whether it works or not, right? So currently, I think we have shifted back to syrup Caletra. The quarantine healthcare workers treated COVID positive patients full PPE, but later you have symptoms. Yes. We give a lot of importance to PPE and how we train them. So the way we work is every time we open up a new ward, we open so many wards, and we almost going to the 9th ward now. So we're going to the 12th ward now. We've got 12 wards now. Every time we open a new ward, what we do is we will train our nurses, and 1 week of infection control link nurses will observe every single person as they go in and come out. So we give a lot of importance to how the staff go and come out, make sure there's no breaks in PPE. So with that kind of supervision, we are fairly confident that breaks in PPE are very rare, right? So if that happens, what we do, they get URTS symptoms, we send them, we do swab them still, but we'll send them home, and the swab is negative and they're better, we bring them back. We don't keep them for 14 days isolation, because we think they don't fulfill the criteria for close contact. Close contact, somebody who comes in contact with a patient without full PPE. Our patients always wear full PPE. We are running low of PPE. Agree with you. In fact, we had a meeting with our KSU, our Secretary General just today, and they're all well aware of it. I think their PPE is on the way. Okay, so hang in there. PPE is on the way, but we have now changed all our protocols to make sure the amount of PPE we use is bare minimum. So now what we do is we line up all our patients. We go after one patient to another, one patient to another without changing PPE. So all our first patients are lined up. So we are doing ward rounds with the same PPE. So we don't change patients. So we are coming up with lots and lots of methods to decrease our PPE usage. And all of you have to do the same thing. When do we round? Should we change gowns between each patient? Yeah. Very difficult question, huh? That one. Do we change? I am proposing if you want, you can wear a plastic apron, the white apron, which has sleeves, and you can change that in between patients, and then and you have to change the glove, just glove and plastic apron between your pneumonia and SARI patients. The other gown you can keep. This is what we do for our PUIs. When we go and see our PUIs, they're all in one place. We just change the plastic apron and change the glove and perform. Yeah, we do ask them to be isolated, continue isolation for another 14 days. That's what we do. Okay. Can we use recycle? We have not reached such desperate yet. So to prevent such desperation, please, we will be releasing soon a new infection control guidelines for PPE. Please follow that and that it works. Thanks.
So we do have another half an hour. Woon and Ching Hun, can you kind of allow some case sharing? Besides with case sharing, I'm sure now most of you have cases in your hospital. Yeah, we are here to see, to all together, we all teach and all learn concept. So if you have any cases to be shared, it would be wonderful. And while you are the other sharing, can you write down what are the topics or direct topics you would like to have for the next session? For example, treating COVID-19 with diabetes or heart disease, things like that. I think this is just one of the questions I have. So what do you want us to do? What CRC staff will do will be we'll go to literature, search the latest publication on this area, and we'll have like 10 to 15 minutes of presentation with Suresh and the others, give some feedback. So write that down while we wait for others to share their cases. Anybody would like to share? Yeah, this is for
issues. Actually, I see a mix of people very uncomfortable issues. Like making their own one, you know, like if you're not going to get the supply, right, I'm just wondering what you think about it. Because honestly, this one is not a virus exposed, especially cough. So what do you think about it?
So for who is just now speaking, can you speak near to the mic because it's not very clear. And also introduce yourself as well, from which hospital you are from, then before you start presenting your case.
People are making, because you don't buy a 60 ringgit one round bit.
You have that. I think there's some people are sending us recipes on how to.
I don't know, I saw one for good. Sorry, your paper repeat.
Proven medical.
Somebody mute. You share a lot of your things with people, is it?
Right.
Because your main appearing in hospital, in hospital, places, my auntie and TYT mothers. All you know, 5%.
That's why I was surprising. Why so many times I just using once only?
We can mute for them.
Possible
With
ke?
the
You use
SOP
your
about case sharing, we are learning.
I don't know.
So,
You submit your name and then they give you the password.
I use this was I think I first never reply my question because I only got the link like 3 hours late.
it's okay. Okay. In future, the person
No, I'm sure the person don't have a raise hand or something.
the raise hand thing I cannot see here. Just now we
I can finish the previous questions first. Let's start from the beginning again. Up some.
read out the question. Read out the question.
Stop. Shoe covers from shoe covers. We don't think we need shoe covers, so we're removing. So as I mentioned earlier, the new infection guidelines will come out soon. Shoe covers are going off. Chlorhexidine bath, no, we don't need chlorhexidine baths. What we do is, initially we used to bathe after every single patient. I think the doctors found it too cold. And our PPE is getting better. We are getting better with PPE. We get more confident with our PPEs. And so I think they finish off the whole rounds first. And next one is, how do you screen for? Okay. I think this is a repeated question that's being asked, right? Isn't it? I think you have to understand. We think there is community spread because we are starting to see more and more sporadic cases coming up. So every pneumonia that is coming into your hospital is potentially a COVID-19 patient, right? And so that's why I'm telling you now again, have a pneumonia cubicle, wear PPEs according to WHO guidelines, which is surgical mask, apron, and eye cover, and screen them for COVID, especially if they look like a viral pneumonia. So any patient, hospitalized pneumonia patient, could be a COVID patient. Okay, and that's how you have to manage that. But don't go overboard with your PPE, right? Because follow WHO guidelines on PPE. Pregnant COVID patient, we are still learning. I think there is a pregnant patient that delivered. Yeah? They have done Caesar today, and we are learning. Unfortunately, we are learning.
From publications.
From publications, nothing is an infection control part. It doesn't get transmitted to the baby. Nothing special with regards to pregnancy and COVID. It is an infection control part rather than anything else. we can send you, what we'll do, we'll send a PDF of the slides because somehow the X-rays, the names are still seen. The X-rays, the names are still seen. We will send you the PDF of the slides over to you, no problem.
Maybe
Okay?
we just take out that. We'll see how.
Fine, we'll see how it goes. Okay. Yeah, materials, okay, fine. And in fact, yeah, if you're still interested, NIH can give you a link to some of the reading materials that you have. We can collect it.
Yeah, as I said, at the end of this session, a team of CRC researcher and doctors will summarize what Suresh has just spoken, because he has shared with us so much of things that we cannot find in journal. It's clinical experience. So we are going to compile important one. In batches, we are thinking of what media. At first, we have created a tutor, but looks like the information will be more. We either go by piecemeal and send out. So stay tuned. We will inform you what media we are going to share, what all have been discussed, plus some of the references, literature that Suresh mentioned, or like clinical outcome. Today's topic is basically about clinical presentation, treatment, and outcome. So we do have some papers on that. So we will decide on a media to share with you. This session is also being recorded. So people who miss a session, we also will think of a mean to share with you. As we are in Sungai Buloh and cases of Sungai, so we would need to be very careful about confidentiality. So we will only share with people whom we know and we trust you to be shared among us and not outside the medical groups.
POI guideline for clinic, I think I've asked the public health when they are bringing it out. When next video conferencing, we will see how it goes. Cross match, yeah, this is a problem, huh? Right? Yeah, I agree with you. It is not a bloodborne virus. We have because when we had needle stick injuries, and one time we were almost about to start steroid for a patient, we were very worried. We actually sent a serum for COVID-19 for 3 patients, and all 3 patients came back as negative. It is not bloodborne, but I can understand the fear in everybody. I think we'll have to sit with blood bank and discuss this issue about group and cross match. I think they don't want to do it, and I think in the days to come we will sit with them and discuss this. Okay. Vitamin C, yeah, I agree with you. It has to be a clinical trial to decide whether to use vitamin C or not. As I mentioned earlier, many of these drugs are better started early, not late. But when you start a drug early in a disease that is self-limiting, it has to be done in a trial setting. Otherwise, we will never know whether we are just giving a placebo or whether giving a treatment. Can we have the current video of your talk? I'm told we will try and record it and send to you. Rapid test is useless. A PCR test turnaround time is so slow for many hospitals, especially big sites. What is the advice? Yeah, good point. This is what happens in a pandemic. Everything gets run out, and we just have to push on and try and see whether the labs are now working on ramping up their test. In the days to come, their tests will be ramped up. The tests will be ramped up. Testing will be ramped up. Hopefully, the waiting time will decrease now. But PCR is only test we have. We don't have any other test currently. What is the next question? Sincere thanks, fighting. Okay, thank you. Do you think Malaysia will become Italy, Iran? Hope not. Hope not. If all of us stay at home and don't spread the disease.
You have to come to work. You have to come to work.
Then fine. Yes, there are some papers saying that ibuprofen makes it worse, but which is okay because we don't use that much ibuprofen in our country, and so which is not a big deal. But there are other countries where, like UK, I think they use a lot more ibuprofen for their fevers. Some data saying that it's not harmful. It's harmful.
Yes, so we have another like 15 minutes. As I said, the system, I suppose your side, many of you are new in mute. We would like someone to share next time from your side, because this is called sharing. Case sharing is not only from Sungai Buloh out. You may have different experience that can be shared with other people. So we will try one more time. You can indicate to the coordinator, Cheng Hun, to see if you want to talk. Then we can we can unmute you. Meantime, as I said, I do want your feedback for the next session. This will be every Thursday. If not Surya, someone else among his colleague or elsewhere, you can actually take the lead. What CRC can do is we need to know who, and you send your slides. Meantime, from that presentation, we hope to have a didactic topic. So let's say if next week you want to talk about COVID patient with diabetes, we do have some paper published on COVID with NCD as well as hypertension, diabetes, heart disease. So that will be our focus. So we do need for you, maybe Suresh can indicate to your colleague out there to give the type of cases, and we have a focus of discussion. You want it to be more focused, also around those. Today is very general because today first one, and it's very important from clinical presentation, management to outcome, and also on prevention. So and many of your practical problems running down a short, low stock on gowns, on masks, even on the swab. So that's our concern. But I was told MKK is already 200 swabs, 200,000 swabs, so it should be here soon. Things like that. Any other questions?
There's 2 more questions.
Okay.
What about
No, I mean, we didn't see much liver problems in the COVID patients, but it is reported that it can affect the liver. We have not seen yet. And so paracetamol usual doses shouldn't be a problem. Can I have email address? No problem. I think I'm sure somebody will pass it to you.
Your personal email address or department or Greg Rakan or?
No, it's, I think they're asking for email address. NSAIDs are contraindicated. Yeah, I presume it'll if we say for ibuprofen, it should extend to other NSAIDs currently. Okay, and I think we have to say all NSAIDs for the time being.
Any sharing from out there? We have about 27 sites listening to this, and also I think colleagues from UKM as well, and UM will join in following week. Yes, we hear you.
No, that's you.
It's echo.
Sure, yeah.
Well, if none, then we may stop this. Everybody's busy. I know it's lunchtime. So thank you very much, Suresh, and all the others. Do give us feedback in whatever means. There's an email that you can write to. We will let you know a same way of registering, maybe better way for next week, same time, next Thursday.
Yeah, I can type
There's a question there. Minimum protection as endoscopists should have on before doing OGDS, colonoscopy. Should we stop immunosuppression drugs? 2 questions.
Okay. Endoscopy. So we discussed this because endoscopy doesn't go into the airways. So anything that goes into the airways will become aerosol generating, right? So if you go past the larynx, it's aerosol generating. So once aerosol generating, it is airborne. And so if it's airborne, then it's N95. So if you're not passing the trachea, then it's droplet. But you can always argue that the patient might cough into you and all that stuff. And so if I were you, I would have an eye protection for endoscopy, be it a visor or a goggle, N95 mask, a gown, and glove. That will be my PPE. And so N95 mask, eye protection, a visor, a gown, and a glove. Immunosuppressant drugs, we don't know the answer to that. I've not seen one with immunosuppression, but traditional teaching is, if the patient is doing well, don't stop. The patient is deteriorating, then stop.
I have a question for ophthalmologists. They were asking, because the mucosa, nose, mouth, how about first thing is tears transmission? What precaution eye doctor need to do when checking patient when they touch,
and make sure they don't cough into you. Maybe offer them a mask. Maybe because you'll be very close.
The sit lamp is quite
sit close to you. Maybe offer them a mask first, and then
running out of mask.
You can. Yeah, that's the most important thing. The most important thing is If they are sick, they should wear a mask, and then if you can't ensure that, then you could wear a surgical mask before.
And also, I think some ophthalmology now they have a self-made some shield to protect their eyes and mouth.
Yeah.
So I think out there ophthalmologists, you can tell ophthalmologist friend, because when we examine patients and ENT doctors as well, we come very close to the patients and accidentally they may cough. So have some nurse, if you're a private eye doctor, have a nurse who do some screening outside, ask some question. If they're sick, I think give them a mask, or you be more careful about yourself. So cover your face with some plastic. You can take some plastic thing, make eye shield that the dental face shield is called, right?
So it's a face shield.
Well, is coronavirus found in tears?
Not that I know. Not that I know of.
Okay. So I think any other questions? One.
Thank you, everyone. Good fight.
So if not, we will correct. Okay. Yeah. Thank you very much.
Thanks.
We see
Any
you.
precaution for dental treatment? Somebody asked a question.
You answer.
Same PPE. Yeah. I think dental treatment, they are quite specific now. It's only for emergency, meaning to relieve pain or infection. They could always avoid routine dental care by just maintaining preventive care, essentially to keep the mouth clean, and surgical chlorhexidine is helpful if you need that. In terms of precaution, PPE is standard for all healthcare providers. So the same thing applies: gloves, goggles, face shield mask, and gown as needed, as necessary.
Okay, thank you. We are practicing social distancing. Each of us are 1 meter away. I hope you do the same. And we see you. Bye.
Bye.
Actually, I have
Yes.
Dr. Suresh regarding.
You have some food or not?
No,
Some food.
had.
You had. Okay, talk. So we finish. So we talk about that.